Hello, everyone, and thank you for joining us today. It's my pleasure to welcome you to this guest lecture on the German healthcare system, a topic of great relevance given the ongoing global discussions on healthcare efficiency, access, and sustainability. We're very honored to have Dr. Sabrina Schubert with us today. Dr. Schubert is a health economist specializing in supply-side health economics in Germany and has been a researcher in the healthcare markets and health policy group at the Leibniz Center for European Economic Research since 2021. Sabrina holds degrees in economics and sociology from FAU Erlangen-Nuremberg with a focus on health and public economics. Her research explores critical aspects of healthcare markets, including hospital systems, workforce dynamics, and the economic implications of health sector reforms, especially in the context of digital health. Dr. Schubert brings extensive expertise in evaluating policy interventions, labor market effects in health systems, and the role of incentives in healthcare delivery and reimbursement schemes. Today, Dr. Schubert will provide an in-depth look at Germany's Bismarckian healthcare model, discussing its historical foundations, regulatory framework, and current challenges, including hospital sector reform, demographic shifts, and system efficiency. Dr. Schubert, welcome, and thank you so much for doing this.
Okay, hello. So a little adjustment here. I'm not a doctor yet, but I hope to be really soon. So just to make that clear in the beginning. And yeah, thanks for having me. I visited Johns Hopkins last year, and I got to know great researchers, and I'm happy to give some knowledge about the German sector back to you students and other people. So yeah, let's dive into the topic. I'm German. I grew up in Germany. I know a lot about the system, and I want to give you a short glimpse into that system, since it's probably a lot different from the systems you know so far. Let's jump just really shortly into the outline of this lecture. So I want to give you a really broad overview how it works. Then the core of our system, which makes it so different from especially the US system, is our statutory health insurance. I want to talk a little bit about the historic roots of that. A big part is then the self-administration and regulation of the system. And because it's very different from the US, we want to look a little bit into the role of the private sector. And then we want to focus on three more or less current issues, which are relevant in a lot of countries, but I want to pose the problems Germany has at the moment, especially when it comes to the hospital sector, when it comes to the implications of the demographic change, and on the broader topic efficiency in the healthcare sector. And I'm going to finish up with some comparisons between the US and the German system. Okay, so let's dive into that. To give you a little bit of context, since Germany is a country within Europe, you might have heard about it. It's really at the center of Europe. It's the largest economy in Europe. And just to give you some comparison, what are we talking about? Let's see some comparison in statistics to the US. So population-wise, it's the largest population within the EU, but it's a lot smaller than the US. So we have about 84 million people, inhabitants. Germany is on average quite old. So if we look at the share of the population which is older than 65, we have more than 22%. That's a bit higher than in the US. The fertility rate is roughly comparable. The GDP per capita in Germany is a little lower than the US, but the equality is a little higher. When we look at something like the employment rate, we see that this is a little lower in Germany than in the US, but in roughly comparable sizes. So just to give you a short glimpse, what is this country besides health that we are talking about? If we look into a definition from the WHO, what is a health system at all? What is it supposed to mean, this word? Then basically they say it's the people, institution, and resources arranged together according to established policies. And so that's already really important things of a health system. So we have a lot of people, institution, and resources, and we need to combine them using policies. And then maybe the most important factor, which is stressed in Germany at least, is to protect people against cost of ill health, and then especially finding all kind of measures to help people and serve the health needs of the population. So that's basically what we look at when we look into a health system. And each country decides on putting a little different focus on different aspects of that. If we want to summarize just some really broad principles about the German health system, we have really the mandatory health insurance as a core principle. So that's very different from the US, and we will talk about that in detail in a second. Another principle is that it's financed by contributions, so we don't pay the system with tax money, but with contributions to health insurances and sickness funds. Then a big part we want to talk about later is also the self-administration and what this means. We come to that in a second. A large topic is solidarity. So the whole system is put on the principle of solidarity, meaning people are not left alone with the cost of their healthcare, and their healthcare cost is not related to the risk of using the healthcare system. And richer people help poorer people. And then the last bit, which kind of complements this principle, is competition. So we also want to ensure some quality people get, and we use some market forces in that system to adjust to some level of quality, or try to ensure some level of quality. And these principles make it kind of unique, because we're not talking about a tax-based system, and we also do not talk about a system which is purely dependent on market forces, but incorporates them. And if we want to look about that in a little bit graphical terms, how are these principles translated into an actual system? So our green person here is our patient, and the patient pays contributions to a sickness fund. And the main idea is the contributions are shared between employee and employer. So it's an employer-based insurance, just like you maybe know the basic principle from the US. And then the person seeks help, seeks healthcare services by physicians or by hospitals, and they will be refunded from the sickness funds, and the payments will never go to the patient directly, but always go to the providers. And then we have the whole idea of how is the system organized, or who is the organizer of the system. And there we have, of course, the legislation coming from the states and the federal government and the parliament. But at the same time, there's a vast majority of competencies which are within the system. And especially we're talking here about the so-called Federal Joint Committee. So all members of the healthcare system, so the Physician Association, the Funds Association, Hospital Association, but also patient representatives, meet in a committee and try to make the decisions for the entire healthcare system. And this is basically what I meant when I said self-administration in the very beginning. And this is basically the different parts we want to talk about in this lecture, to see how the different parts of these organizations work. The most prominent thing is, of course, the mandatory health insurance we have in that country. And this serves kind of two purposes. The first thing is more or less service coverage. So we want to ensure that all people can use health services, and we want them to be available in sufficient quality to everyone to be effective. The other part of it is that there should be financial protection for everyone. So we want to make sure that people do not experience financial hardship because of health issues. And we don't want people to end up in a lot of debt because of health issues. If we look at the US, there's no mandatory health insurance. And we see in that statistic I just put up there that there's like a few percentage point of people who are uninsured. So it's roughly 8% at the moment who are uninsured. So in Germany, because of this mandatory health insurance, we are close to zero. And if we look at the main part of these insurances, this is the statutory health insurance. So this is maybe the interesting part. How does that exactly work? So let us look a little bit into the historic roots of that. So sometimes, and also the title of this lecture is called like a Bismarckian system. And why is it called like that? Because the guy who invented it was Otto von Bismarck. He was a chancellor of the first unified Germany. So back in the day, Germany was a lot of states, and then due to several wars, it was finally formed into one country. And this Otto von Bismarck was a really key player in that historic game. And he was a smart statesman. And he lived in a world where industrialization was happening, where a lot of people coming to the urban areas, families lived in very, very bad conditions, and there was a rise in socialism and ideas that workers should have more rights. So the capitalist or the socialism movement was really big in Europe back then. And he realized, okay, we need to do something about the bad condition of workers. And the first idea which he took into practice was actually introducing a health insurance system. And his idea was having an employer-based health insurance system. So the basic idea, it's beneficial for the employer and the employee if there's sufficient health services for workers available. So the payments should be half by employees and half by the employer for the health insurances. And to make the system based on solidarity, the idea was to introduce a system that is not risk-based, but income-based. So everyone pays the same share of income towards the health insurance. Similar systems were later introduced in Germany, and he had also the idea to introduce an accident insurance and old age pensions, so basically a retirement system. So that's why the Germans always look back to Bismarck and say he's more or less the founder of the modern welfare state here. And the ideas kind of split from there also to other countries to introduce similar, especially health insurance systems. So as I said, the motivations were mostly the circumstances of the times, and also it was a little bit of nationalistic thinking as well, that healthier workers could be good for a country. If we look at what does the model exactly, I also referred to some points already, is that it's employment-based. So people in the beginning who were not employed were not insured. So the Bismarckian model in itself is not a mandatory health insurance system. But for everyone who was employed, it was a state-mandated social insurance system. It's funded by contributions from workers and employers. And then it was back then already introduced that the sickness funds, how we call those insurances working in this public scheme, reimburse physicians and hospitals and other providers directly. So there's never a payment to the patient, but exactly to the provider. As I said, there are some principles related to this model. So as I already stressed, the solidarity principle. So it's a shared financial risk across society. So not a shared risk for health, but a shared financial risk. So everyone pays based on income. He also back then already set up that idea that the state does not organize the entire system, but he put up insurances, sickness funds, who are managed independently and not by the state. And here also comes in the idea that we also have some market forces in the system with competition. Since we have multiple of these sickness funds which compete against each other, we think that there might be also quality improvements in how sickness funds behave. Let's compare a little bit to other more famous systems in Europe. This is more or less like a national health service, like in the UK, which is more like a tax-based system. So these tax-based systems, the idea for them comes in way later in time, so roughly 60, 70 years later. And the original ideas are a little bit different. So one has to admit Bismarck mainly had in his mind keeping workers healthy. And now in these like more tax-based system, the basic idea was health is a human right for everyone living in this country. And then how it's financed is really, really different. So the funding base is on the Bismarckian system, as I just said, on employer and employee contributions based on wages, and in like a national health service, is paid by general taxes. These two systems are very common in Europe. Most prominently, we have Germany and the UK with one of both systems. But statutory health insurances were also introduced in other countries like France. The mandatory insurance is not as old as one can think. The Bismarckian model is really old, with the health insurance being already introduced in the 19th century. But the idea that everyone needs to be insured comes in way later, not before the 2000s. And one reason for that is, as I stressed, this Bismarckian health insurance was basically based on employment. And as you know from the US system, if I tie insurance status to employment, not everyone is insured. And that's also one reason why a second kind of system was introduced. But first, let's talk about how exactly does this insurance system work today. The basic idea is, as I said, all right, insured people pay their contributions according to their wages shared with the employers to health insurance funds. So now we run into a problem, because since the contributions are based on wages and not on the health cost or risks, this might not align if there are several health insurances. So some health insurers might have really healthy, well-earning people, and others might have a very large share of old people who don't earn that money anymore and need a lot of help. So it does not work in that way that the contributions go to one specific sickness funds and then go back to the providers immediately, but we need a kind of redistribution between them. And this is actually what's happening. So the contributions from all people and from all sickness funds get transferred into something we call a healthcare fund. And that healthcare fund is also feeded for people who are currently unemployed and for retirees. So basically the scheme from the old Bismarckian days was extended. So now we also cover people who are unemployed and people who are not employed anymore but retired. in the last decades, all these contributions were not enough anymore to cover all healthcare costs of the people who are insured in the system. That's why it's not true that it's not a tax-based system at all anymore, because it is by now. Because the state needs to bring in now money into the healthcare fund to avoid losses for the health insurances, since contributions are not enough anymore. We come to that problem later. And if we then have all that money together, the question is, how does it get back to the insurances, right? And the basic idea is, okay, let's give the insurances back the money for each insuree. And each insured person might have different risks or different costs in the healthcare system. And so based on individual diagnoses, age, and sex, out of the healthcare fund, each insurance receives, let me see. Each insurance receives a payment for every individual, which is insured with that specific sickness fund. So there's a whole redistribution channel according to diagnosis, age, and gender. Once the money is back at the insurance can pay for the providers. And as I said, the money does not go to the insured person and then to the provider, but always directly to the provider. As I teased already, this system is not the only system that exists, because the idea was born from an employer-based insurance, and not everyone was employed. So back in the day, a second branch of insurances started to exist, private health insurance. So it's a really unique dual system where people can be privately insured only if they earn enough, if they earn among a certain threshold, or for example, civil servants or self-employed people. You can think of that like a country wouldn't set up such a system anymore, but since the historically grown roots of the system, these were the people, especially self-employed and civil servants, who were not covered under the Bismarckian system. So the state and self-employed people needed to come up with other ideas. And that's when a private health insurance market was established, just like you know it, like any other private health insurance market, just with the restriction that not everyone can join that private health insurance market, but we enforced regulation that only people earning beyond a certain threshold can actually join the private health insurance and opt out of the statutory health insurance. So that's really unique. Let's look a little bit at the differences here. So we have the statutory health insurance, as I said, financed by contributions based on wages. So by now we're actually on roughly 17% of the wage going to the health insurances. And for the private health insurances, just as you expect, there's just risk-related premiums like you would know from any other health insurance. If we look at how many people are covered by each of these schemes, so the vast majority of Germans is covered in the statutory health insurance system. So roughly 90% are covered here. And then roughly 10.5% of the population are covered in private health insurance. You see there's a little difference in there. This doesn't add up to 100. Why? Because there's some really different schemes, for example, for veterans, for example, for policemen. So there are some different state schemes for other occupations. So that's why it doesn't add up. The insurers, as I said, we have the sickness funds, and I said there's competition, and we still have 94 of them, but the number dropped immediately in the last decades. Originally, for nearly every occupation, there was a different sickness fund. They are self-governing, so they're not part of the government. They are not a public they're not a part of the public government. However, they are under public law, and now there's a special thing about them. They cannot make any profit. So it's forbidden for them to make profits. So this is a really crucial difference between a private health insurance and the sickness funds, because a private health insurance, of course, can make profits. The basic idea of the sickness funds is just to get money from the wages to the providers in a redistributional fashion. They are very differently regulated. This is maybe just for details, but they are very differently regulated. And then now the big question, because that's very different from other countries, is okay, but how is it with the providers? Can the people use all of them, or have the private health insured more access? And it's true that the people and the statutory health insurances can only go to contracted providers with the statutory health insurance system. But since nearly 90% of the people are within that system, basically it means that roughly 97% of all ambulatory care providers are contracted with the system, and 99% of hospital beds. So basically there's still a free choice of all providers. Just some really, really small private entities cannot be accessed. And of course, the private health insurance have free choice. These plans, like in the US, where you have just a specific hospital you can go to with specific insurance, are not common here at all. So basically it's free choice. This is also due to the payment of providers, which we come to in a second.
Sabrina, can I interrupt you for a quick question about the private insurance? Can people, can people like use private insurance to supplement the insurance they get from their sickness fund, or if I want to use private insurance, I have to completely opt out of the statutory insurance system? How does that work?
That's a good question. So there's of course the possibility, if you're in the public health, if you're in the statutory health insurance, you can top up with some private insurance, right? You still pay your contribution, so
Okay.
you use most of your services within the statutory health insurance, and then you maybe have like a additional dental insurance or whatever. That's perfectly normal, and a lot of people have that if they want to. But if you want to like use most services via the private health insurance, you're out of the public statutory health insurance. So, but yeah, you can have those top-ups. That's people have it for glasses sometimes if they don't want to pay like their share, which they need to pay in the statutory health insurance, for example. Yeah.
Thank you, Sabrina. But so the way it used to work in the past was that you could only get private insurance if you earned above a certain threshold. And like you mentioned that, right? And you had to opt out of the statutory system. Was that how it was originally intended?
I mean, still, you can only get out of the statutory health insurance if you are above a certain threshold.
Okay.
So you're obliged to stay within if you earn less, or if you're, I mean, self-employed people are out of that, even if they earn less, they can be in private health insurance. But you can have as many assurances as if you want, but you cannot get out of the statutory health insurance under the income threshold.
Great. Thank you.
Yeah, that's still the case. And it's more or less, to be honest, to ensure that people stay within health insurance, which they can afford. So it's more or less, taking this potential risk away from the people.
Thank you.
The next part, I already talked a little bit about it, but only in really short terms, is the self-administration of the system. And if we look at the map, or this graphic, which I already showed you in the beginning, we talked a little bit about the middle section of it so far. So basically, okay, sickness funds, there's a mandatory health insurance, but to paint a full picture, we also said, okay, there are some people who are privately insured. And now it's basically the question, but who organizes the whole system? And I already pointed out there's this federal joint committee of the different members, and we want to look into a little bit more detail, how does this part exactly work? And to give like a general picture of it, this self-administration is introduced to make sure we do not solely rely on the state, but also not solely on the market forces. And that's why responsibilities are divided between the government, states, and more or less institution at a corporatist level. So the role of the state, like the federal government and the federal states, are more or less to define the framework in which medical care is taking place, giving legislation to guide the whole process, and there's a big part in like public health. Yeah, public health is more or less the field of the governments, and they provide project funding for things like the National Cancer Control Plan or National Prevention Plan. The principle of the self-administration then is that once this legislation is done and this guiding regulation, decisions in the system are made within the system. So especially, for example, how exactly is the structure of the healthcare system? How exactly do we finance it? And the key actors in that system are all doctors, dentists, hospitals, the sickness funds, and the insured people. The most important committee in that sense, where all those come together, is the so-called Federal Joint Committee. And in the end, they regulate the whole statutory health insurance when it comes to any issue of access, benefits, or quality. So, for example, this committee defines binding guidelines for all the services which are covered. So since we have 94 different health insurances, we need to make sure, okay, we stick to a certain plan which services are covered. And so in Germany, we are at the moment in a place where roughly 99% of the services have the sickness funds cover are the same, because they are agreed on that all these sickness funds need to pay for them. But not only what is provided, they also assess what should be done, and then also assess new things like new treatments, new operations, new therapies, new medicines. So, for example, the German way of introducing new medicine to the system is the so-called AMNOG procedure. And this committee decides more or less whether or not a new drug on the market has an additional benefit compared to all drugs, whether or not it should be in the plan for all the people, in the health insurances, and then for which price we're gonna buy it. So this kind of self-governing body is really powerful in that sense, since it organizes really all the access, all the quality, all the benefits within the health insurance, at least the statutory health insurance. And they are a really big price negotiator. And you can imagine they have some power in that. When 90% of people are insured within your system, you have some real negotiating power. And they also fix the rates, not only for medicines, but also, for example, for physicians. So how much money gets a GP if he treats you? These kind of things are all negotiated on that corporatist level. And you know, there's as I painted here, so maybe the health insurances have some incentives to save money, but the physician association, of course, wants to maybe increase the income of physicians. So they really need to find good solutions for everyone in that committee. And the federal government cannot talk too much into that. This is more or less a self-governing body, and it's also, of course, an important part due to the history of Germany. And I want to like put out one care provider which is represented in that joint committee, and that is, for example, the Association of Physicians. So all physicians which are in the outpatient sector or ambulatory care sector who want to treat people in the statutory health insurance need to be part of the Association of Statutory Health Insurance Physicians. And they have their association, which then has also some power over the whole sector. For example, they need to organize the medical services of office-based doctors, which means on the one hand side, they can say, where do we need physicians? But on the other hand side, they also have the duty to find physicians if maybe an area is underserved. So in these associations, different rights, but also duties come together. That's what I want to stress here for this like self-governing part, which also means that sometimes this federal joint committee with all their members and the Ministry of Health maybe do not have the same ideas and get into some fights how to do things best. But in general, it's more or less communication across the different fields.
Sabrina, this is super interesting, of course. So I have a question, and forgive me if you mentioned it already and I missed it. So the 94 insurance entities, how do they differentiate? Are they differentiated from each other, or do they kind of pretty much offer similar coverage? And how does a person choose which insurance entity to join? Is that based on occupation? Can one switch insurance? Could you say a little bit about that?
Yeah, sure. So it's again something which is interesting because it's historically grown. So it used to be the way that it was tied to your occupation. For example, there's a Techniker Krankenkasse, which is the sickness funds for technical people. So basically, these were all these engineers, for example. Then in the late 90s, it was decided, okay, we need more competition in the market. And it was decided that everyone can choose every health insurance fund. Every sickness fund. So basically, people can now choose, and people can switch if they want to. The basic reasoning for changing is that most services are the same, as I said, roughly 99%, but sickness funds can decide on what to do on top, given the services they need to provide given by the Federal Joint Committee, so they can provide some more services. For example, a thing which is covered by some insurances and some not is vaccinations for vacations. So if you go into a tropical country and need some vaccinations before, some insurance is covered and some don't.
Okay.
But this is only like I'd say a tiny margin how they can differentiate their services, which they actually cover. And then they have a second part. I tried to skip it because it's complicated, but now that you asked it, I will tell you, is that so there's a fixed share of the wage which you need to pay for the social health insurance scheme. And then each sickness fund can decide on a top up. So for example, they can add up 1.6 percentage points, or so roughly everyone pays 17% at the moment, shared between employer and employee, but it varies by a few percentage points up and down depending on your sickness fund. So basically, if you are really price sensitive, you might just decide for the sickness fund, which has the lowest additional top-up rate.
I see. So there's a little bit of competition by price, on price, a little bit, and a little bit of competition on sort of supplemental coverage of certain specific items.
That's exactly right. And you already stressed a little bit and a little bit, and this
Yeah.
of course leads to not that many switching every
I
year.
see.
So there's not huge switches. So most of the people just remain and where they have always been.
Very interesting. Thanks for clarifying those
No,
really
sure, yeah.
really interesting details.
Let me just get back to what I wanted to say. Yeah, if we look into providers, then like away from the insurances, more towards the providers. As I said, 90% of people roughly are within the statutory health insurance. This means basically most providers serve both populations, the people in the statutory health insurance and in the private health insurance. Because the statutory health insurance is just the majority of people, and the privately insured are maybe the ones where you can charge a little more services. Patients have the free choice where to go to, so it's not like there's an insurance plan which says where you need to go first. And then GPs are usually the first contact with the healthcare system. It's not a necessity, so you're not obliged to go to the GP first, but people are just used to going to their family doctor, their GP first, and then get referred to other parts of the healthcare sector. And most of the primary and ambulatory healthcare is provided by small private for-profit entities, like the typical practice you imagine, like one or a few more GPs working under one roof. And this might be not so different from other systems, you know. What is less common are these huge outpatient centers. This is not, maybe in recent years they have popped up some, but that's not the majority so far. And just maybe to give like a little glimpse in how they are paid, right? So GPs are basically paid by a combination of a large share of a capitation when contact happens, and a fee for service and some top-ups. It's the special thing about specialists in Germany is that we all have them also in ambulatory practices. So if you want to see a specialist, you don't have to go to the hospital. You go to a practice. That's some form of specialty, and we also pay them with a contact capitation and a fee for service. But the fee for service here is much higher than for the GPs. Interestingly, for hospitals, we use DRG, so you might be familiar with that from your system. And also interestingly, in GPs and outpatient care, there's a little bit of difference in payments between private and statutory health insurances. In hospitals, the private health insurance followed the statutory health insurance and adopting more or less the same DRGs. So there's basically no difference in reimbursement. And yeah, then maybe the most interesting thing is that also pharmacies get a margin for each product they sell within the systems. All right, maybe just one further note on how is the coordination of payments. And I want to say that because in this first graph I showed you, I basically said, okay, and then the health insurance funds pay the people. But of course, it's a little bit more difficult. And I just want to show that to just stress how important these associations are. So because the payment usually goes not directly to the doctors, but for example, for the ambulatory physicians, the payments go to the physician association, and the doctors get their money for all people from all insurances which they treated from the physician association. So these associations, I showed that because I want to stress how important they are within the system. Okay. I want to change a little bit the topic of it because I know that most of you are familiar with the US system, and what I want to show a little bit the differences of the private sector in the healthcare system between the US and Germany. And of course, this is not every aspect you can think of, but I thought this might be the most interesting aspects of the system. So in some aspects, we're not so different, in some a lot. And the first thing I want to say is a lot is discussed about hospital ownership in Germany. And we have roughly 1/3 public, 1/3 private non-for-profit, 1/3 private for-profit hospitals. And it's a topic because the share of private and private for-profit hospitals increases a lot since the 1990s. So also in the US, you have that rather mixed thing where you have public hospitals run by the state or local entities, and also non-profit hospitals and for-profit hospitals. I think the big difference is that these big chains are quite a thing in the US. And there's also hospital chains in the US, but the consolidation of the market is not as dense in Germany as it is in the US. And then I think what is a real difference is the regulation of private entities within the healthcare system. So there's really strict oversight of private providers, especially when it comes to hospitals. And I feel like the regulation in the US is a little less tight. The ambulatory providers, as I already said before, are also private in Germany, like a GP would be a private entity, but they are rather small. And I think like in the US, it's more mixed between small and larger providers, but they're also private. So that's a similarity between the two systems. And then, of course, the biggest difference, we talked about it a lot, is that the statutory health insurance is a non-profit and like a semi-public entity, and the insurance system in the US, of course, you know, it's mostly private, besides like Medicare and Medicaid, which only can cover specific groups. Which basically means that within health insurance, there's not that much of a private market. There is a private market for those 10% and for the top-up insurances, but it's just a completely different market structure. And I guess without like generalizing too far off, but this kind of gives the picture that privatization and private entities exist in the German healthcare sector. The healthcare sector is even based on them in a lot of parts. But if they exist, they're highly regulated, and the insurance market is completely different. And the US system is a lot more market-driven and with less regulation. That's the takeaway I wanna point to. And then maybe let's talk a little bit about a sector I didn't speak that much about it. We think it's like the most discussed sector in Germany at the moment, and that's the hospital sector. And I want to talk about why that is, and maybe this is not so different from other countries, and maybe it's a little different from other countries. So in the German hospital sector, we have a really high number of inpatient people, and we have really high bed capacities compared to other countries. And the question is always a little bit, okay, what causes the other, right? If there's a lot of beds, they are filled. That's why we have high number of cases. If there's a lot of cases, we need a lot of beds. So that's kind of a chicken egg problem. And as I said, we have this DRG reimbursement system, which also incentivizes hospitals to treat cases because it's a case-based reimbursement system. At the same time, the hospitals face a lot of financial distress. In Germany, we see they run into bankruptcy, and we see a lot of hospitals report struggles. And some regulation background hospital planning, like where should be a hospital, is done by the states. And the individual states should do it, and they do it. However, the process is often unstructured and not too transparent. And mostly they just they publish a plan which just basically is tied to the hospitals which already exist. Why are these plans so relevant? In order to get money out of the statutory health insurance system, you need to be able to be in that plan. You need to be in that plan to get money out of the system. And just to give you a first glimpse, so on the map, right, some of your geography knowledge is now challenged. So this is Germany and a neighbor country. So the ones who thought it's just Germany, it's not. In the north, we also have Denmark. And Denmark all has consolidated its hospital sector already. And what you can see, the pink dots are hospitals in Denmark and the black dots are hospitals in Germany, and you can really see a difference, right? Even if you might think there's a little different population density and stuff, but you can really see a difference. So we have a lot of hospitals. Let me illustrate the problem even a little more. So this is the bed capacity we have. And as you can see, a lot of countries had quite high bed capacities in their hospital sectors, but a lot of countries also managed to bring them down. And in Germany, we really have a lot more bed capacity for the HILS measured per 1,000 people than in other countries. So there's a lot of capacity. At the same time, we usually would have, compared to other countries, also relatively high numbers of doctors and high numbers of nurses. So if we here are compared to some, so this is basically all the EU countries, and some are marked, some dots are marked. And you see that in Germany, compared with other EU countries, we have quite a high number of nurses and high number of doctors. But since we have so many beds and so many hospitals, the nurses and doctors per hospital bed are really low, the figures. So there's this feeling that we lack professionals, but it's a matter of how we distribute them. One other aspect here I want to show, which is a real problem, in my opinion, for the German sector, is that we have so many small hospitals. So what I show you here is it's the sum of all hospitals, but the hospitals are divided by the number of beds which they have. And if you, for example, look at the bottom green line, these are hospitals which have less than 50 beds. So they are really small, and there's more than 300 still of them in Germany. So the hospital sizes and bed capacities were reduced, but mostly in large entities, but we still have these small entities, and people more or less still want hospitals around them really closely. But at the same time, this might not ensure a high quality treatment in these really small hospitals. So
sorry, Sabrina, I sorry for interrupting you, but this, when you were just saying just what you just said about how, politically difficult it is to consolidate hospitals, I observe exactly the same sentiment in Italy. That's where I'm from originally, where, people really value having a hospital close to where they live. But often sort of not appreciating the fact that if the hospital, yes, you have a hospital that's close to you, but if it's a small hospital, a hospital that doesn't have all the specialties that are important, that it's not that valuable to you. So it's difficult to convey this to this trade-off, right, to the population in Italy, and I'm wondering if it's similarly difficult in Germany.
Yeah, so that's exactly more or less. It's also really difficult, and the government basically what they did is to set up a commission to see how it could be reformed. And I put here some of their proposed elements. And before I go through them, it's basically now that it went through Parliament. It took a lot of forth and back the states were against a lot of those ideas, then some were in favor of it. And now the last year was really up and down for that new hospital regulation. And we'll see how what happens now, because officially it's now through Parliament, but still some people are really not fans of reorganizing the sector. So, what you said on Italy, I guess like most of it also applies to the population here. People just have the feeling that they want to have a hospital close by, but then quality-wise, maybe that's not a good idea. Yeah. And so the basic things they want to work on now, which were on this first commission's proposals, some made it now through Parliament, some didn't, was to build up a classification system for hospitals in 3 tiers, to make clear that in a radius which is larger, there's a hospital which can provide every care, like a university hospital, then have middle tier hospitals, which are in a certain radius, and then maybe have these like really low level tiny hospitals, but they then can only do very little. So they can't do all the services anymore, just to ensure some quality. And how is that defined with that tier hospitals? The idea is to introduce service groups, and each hospital needs to be assigned to some service groups they can provide and some they can't. And yeah, some other ideas were introduced, and we'll see which parts of them happen. What's an interesting idea, if we think about how we organize systems in reimbursement terms, is that the DRG payment is reduced to 60%, and 40% is more or less a fixed budget, which is not case related anymore, to take a little bit the financial incentive away to have a lot of cases. I think the last issue, more or less, I want to talk about with you is really tied to this idea of solidarity. We don't have risk premiums for our health insurances, but they are based on wages. And Germany faces a large problem with that, since we run into a large demographic change. We call them, the so-called baby boomers are now retiring and will retire in the next 10 years. So we lose a lot of labor force, which is not replaced, because the birth rates were just a lot lower when they had kids. And so we have that problem that a large share of workforce leaves the healthcare sector, so we lose health professionals, and more people need care, and at the same time less people contribute to the social security system. And this is a real problem in a system which is based on these statutory health insurances. Just to illustrate it a little bit more, just as you might imagine, this is like the average cost for the statutory health insurance of a person. And you see, as you might expect, that people get older, they're more costly for the health insurance. And now this is the problem in Germany, or one of the problems, that the share of people in the health insurance which is old is getting a lot higher. And we need to figure out ways how to cope with that in our system. Just let me briefly introduce you some issues which I think are interesting. In general, Germany is really good in providing access to care. And as I said, the country really stresses that. And if we compare Germany to other countries, there's really little out-of-pocket spending. People also, so on this chart, report if their medical needs are unmet, and nearly no one feels that way. And there's also no differentiation according to income. So this is what this system really achieves. And I must also say, at some point, waiting times are not a big issue. Maybe I need to take out mental health here a little bit, but generally wise, waiting times are not a big issue. So this access thing does really work in that system. And this also leads maybe to relatively high use of the healthcare system. So compared to other EU countries, at least, we have high inpatient use and also high outpatient use of healthcare services. So in generally, people have good access, but people also use it. And this basically meant in the last decades, not only these facts, but generally, we have, compared to other European countries, really high expenditures on healthcare. And I just put the chart on the right side to see, like, it's still a lot lower than in the US. So the European countries are generally providing a little bit cheaper healthcare. But within the EU, one really sees that the costs are really high of that system. And I just showed you that demographic change. So this will even increase further the next years. And by now, Germany pays roughly 12.9% of its GDP in the healthcare sector. So that's a large share of expenditure. And then the question is, does it really translate all that high use, that high cost into good health? And one can look at different indicators. Like if we would look at the life expectancy, Germany would be a little below EU average. The expectancy would be higher than in the US. But if we look at measures like avoidable mortality, then these high expenditures and this high use is not really represented in the figures. And this is more or less why I labeled the current issue efficiency, because the system really needs to think how to allocate resources in a way that makes the population really healthy. And this is maybe not always given at that current point of time.
Sabrina, can I just make just an observation? Research from the US mainly actually indicates that differences in health across people are not mainly due to differences in access to healthcare, but at least again in the US, they're mainly due to differences in lifestyle, nutrition habits, and so the things that contribute to health again, but that are not healthcare. So, and I'm wondering if there's similar research from Europe. I'm not sure, but I would be curious, whether it is the case in Europe as well, that differences in health, to what extent differences in health are due to differences in healthcare systems versus differences, what people eat, whether or not people smoke, whether or not, what type of diet they have, exercising habits and things like that.
Yeah, I mean, sure, a lot of these things play a role. I don't know like causal research, but I know the figures for Germany, and then we know that on average more people smoke. We know on average people, then like on average more than the EU average.
I see.
More people drink. So there is of course some of the lifestyle factors which also play a crucial role here. Yeah, for sure.
Thanks.
Yeah. I get there might be an expert on those studies. I'm not, but I just know the statistics, and I know that in a lot of these lifestyle decisions, Germans make rather poor decisions. Yeah, compared to the EU average, at least. All right, let me finish up with some comparisons I think are interesting between the American and the German system. So we talked really in detail about like this universal health coverage with this Bismarckian model of statutory health insurance, compared to a really like mixed system in the US with some public and parts of it like Medicare and Medicaid, and mostly employer-based private insurance. Then if we think about coverage, then we have a mandatory coverage for people in Germany to be insured. And then at the same time, we know that the statutory health insurance and the private health insurance cover a lot of the care people use. Out-of-pocket expenditures are really low compared to other countries. We know that the coverage in the US is not universal, so it depends on the figures, but roughly 8% of people are uninsured, and the coverage can be really different for different people. if we look at how are things funded, again, in Germany, employer and employee pay contributions, and some tax subsidies, as I said, because the system becomes just too expensive to be just covered by the contributions. And then in the US, out-of-pocket payments play a larger role, and the premiums, of course, as well. When we think about cost control, so cost control, I mean, there's regulated prices for services in medicine in Germany, so there's a huge cutoff in costs. And then at the same time, the prices between insurers and providers can be negotiated in the US on whatever terms, so there's a lot more variability. If we think about access to care, there's a really broad access to the services in Germany. We talked about that enough. The access in the US depends a little on your insurance type. So it's more that people need to take care about their access themselves. And then if we think about the choice of providers, the choice of providers is basically free in Germany. As I said, 97% in the ambulatory care work under the statutory health insurance scheme. And then if we think about the US, there are more restrictions to it. If we think about comparing the US and Germany when it comes to health outcomes, one needs to be a little careful, I guess. But in general, we can think of comparing just those two countries. There's lower per capita spending in Germany than in the US, and on average, a little bit better health outcomes when we think about avoidable mortality and expected lifetime. Yeah. So the German system is basically not really always the best, but compared to the US, in some aspects, at least, maybe favorable. And let me do some final remarks to conclude. So we learned today the Bismarckian system goes back long time, and it needs to adjust to modern times. It is already adjusted in some form. So as I said, by now there's a mandatory health insurance. It wasn't back then, but still it needs a lot of reforms nowadays. And the big kind of overarching topics which are a problem is the workforce and demographic changes which are related to that, and the cost. Yeah, I showed you we have quite high costs within Europe. Yeah, and then we face further challenges. I didn't stress them in this talk, but as you might know from other countries, long-term care is a big topic. I didn't talk about it today, which is, of course, also a problem with the aging society, which we have. There's a similar scheme like the statutory health insurance for long-term care in Germany, but we didn't touch on that. But this is something which needs to be reformed at the very moment. Emergency care, we didn't tackle that, but also like in a lot of countries, it's a problem to organize it for the modern times. And then what doesn't really work that well in Germany compared to other countries, and I don't want to hide it from you, is that this cross-sectional care. And there's an ongoing reform at the moment, but we have elections coming up soon, so no one really knows which kind of these proposals go through or not before that. So we'll see what the next government and the next coalitions in Germany do in the health sector. Which will be interesting because it's economically different times now. It's difficult times, and that's why it always is interesting to follow other healthcare systems to see what they do, in which political circumstances, and to which cost. So yeah, just let me tell you, I found it really cool to be invited to give this talk, and I hope you can learn something from it. And if you have any questions or remarks, then feel free to email me.
Sabrina, also on behalf of my students, thank you so much. this was a wonderful lecture, incredibly informative, super clear. You mentioned, you know, that elections are coming up in Germany and that changes might be happening. So perhaps we do another conversation, another lecture next year. But for now, let me thank you again so much. Very,
Okay.
very grateful
Thanks for having me.
for your lecture.
Thanks.